بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are now discussing the issue of peritoneal and mesenteric imaging, which is considered the last topic in the series of abdominal imaging. And I will divide this talk into two parts because it is relatively long. In the first part, I will discuss the issue of peritoneal imaging, and in the second part, I will discuss the mesenteric anatomy and pathology. Then you know that for imaging of the peritoneum and mesenteric lesions, we may use different imaging modalities, including ultrasound, CT, and MRI. And in my opinion, CT is now the modality of choice for evaluation of peritoneal and mesenteric diseases. And this is the suggested technique whenever you are dealing with some of these pathologies. The eye or it is recommended in the literature that the scan interval is about 3 millimeter section thickness, and you can use the field of view of 35 centimeter. And it's very important to have these 2D reconstructed images in the coronal planes in particular, and also you may use the sagittal orientation as well. Of course, in many situations you need to inject intravenous contrast media in order to have a full anatomic details of the vascular anatomy and pathology in this area, which is very important for the diagnosis, as you will see. Now you know that the peritoneum is a serous membrane which is similar to the pleura and the pericardium, and the abdominal organs are either intraperitoneal or retroperitoneal in location. And it's important to know that the peritoneum and mesentery in most of the cases are not usually visualized in normal conditions. Then the peritoneum can be seen, and also the mesentery, whenever there is some pathology which produce some changes in the peritoneal or the mesenteric fat. And you can see in this example there is some abnormality here in the peritoneal fat. If you compare this fat, which is relatively clear, to this fat which is referred to as smudged or stranded or dirty fat appearance, and there are a lot of lesions that can produce such an appearance in the peritoneal and the mesenteric fat planes. Then this sagittal diagram shows the intraperitoneal structures, and the peritoneal cavity is presented here in purple color, and these are the structures which are lying inside the peritoneal cavity. And you know the retroperitoneal structures are located posteriorly adjacent to the spine, and the space which is colored in yellow is known as the subperitoneal space, which is just some of the reflections of the peritoneal and mesenteric membranes. Then we have in intraperitoneal organs, which include the stomach, the spleen, the liver, the duodenal bulb, the jejunum, ileum, transverse colon, and the sigmoid colon. The extraperitoneal structures include the rest of the duodenal lobe, the cecum and the ascending colon, the descending colon, the pancreas, and the kidneys, which are of course located in the retroperitoneal area. Then there are some of the important definitions we should know in order to understand well the pathology going on in the peritoneum. The omentum is a peritoneal folds which are connected to the stomach. The lesser omentum is connected to the lesser curve of the stomach, while the greater omentum is connected to the greater curve of the stomach. Then the parietal peritoneum is the layer covers the abdominal wall. The visceral peritoneum is the layer of the peritoneum that covers the hollow and the solid viscera. It's almost similar to the pleura. The parietal pleura is against the chest wall, and the visceral pleura is covering the lung. Then we have said that the omentum is the fold that is related to the stomach. The lesser omentum is related to the lesser curve, and the greater omentum is related to the greater curve of the stomach. And the mesentery is the peritoneal fold, which is connecting the bowel to the posterior abdominal wall. And a good presentation here is the mesocolon, which is connecting the transverse colon to the posterior abdominal wall. Then you know that the peritoneal cavity is divided into two sacs or cavities, the lesser sac and the greater sac. And the lesser sac is small and is located posterior to the stomach, anterior to the pancreas in this particular area. And the rest of the peritoneal cavity represents the greater sac. And there is a connection between the lesser sac and the greater sac, which is the foramen of Winslow, which is related to the region of the porta hepatis. Then this is a very old technique which used to inject some contrast media inside the peritoneal cavity through needles introduced percutaneously into through the abdominal wall. Then this contrast media is filling the peritoneal cavity, and you can see that most of the liver is inside the peritoneum except for this small area which is in contact with the diaphragm is known as the bare area of the liver, and also there is a small area of the spleen which is also in contact with the diaphragm, and zone area is known as the bare area of the spleen. Then the lesser sac, as I have said, is located posterior to the stomach, anterior to the pancreas, and is connected to the greater sac through the foramen of Winslow, which is almost approximately located in this particular area. Then this is just an example of a patient, a child with a history of abdominal trauma, and she got lacerations in the liver, as you can see, and fluid in the lesser sac. And this fluid is of course hemorrhage, and this is hemoperitoneum. This is the stomach, and this is the pancreas, and this is the lesser sac. You know that the lesser sac is usually collapsed, and you cannot see the lesser sac except it's filled with some fluid like blood or pus or something like this. Then this is an example of acute pancreatitis. You see that the pancreas is relatively swollen, and the peripancreatic fat planes are obliterated by fluid density, and there is reticulation of the fat, and this arrow points to the fluid which is located in the lesser sac, secondary to acute pancreatitis. And this patient with a history of blunt abdominal trauma showing a big hematoma in the lesser sac. This is the stomach, and this is the pancreas. Then the space between the stomach and the pancreas represents the lesser sac, which in this case is filled by a big amount of hemorrhage. And also you can see this fluid around the liver, and this fluid around the spleen also represents hemorrhage, as I have mentioned in the lecture of abdominal trauma. Then what are the items that will be evaluated in this lecture? We are going to evaluate intraperitoneal fluids, peritoneal inflammations, peritoneal cysts and tumors. Then in the second part of my talk we will cover the issue of mental and mesenteric lesions, and these include will include the rotational anomalies, vascular lesions, mesenteric panniculitis, missed foreign bodies, mesenteric cysts, malignant tumors, metastatic disease, and finally the issue of the pseudomyxoma peritoneum. Then intraperitoneal fluids will include simple fluid like ascites, blood, hemoperitoneum, pus, peritonitis, and also will say some words about intraperitoneal air or the pneumoperitoneum. Then ascites is accumulation of fluid in the peritoneal cavity, and you know that there are a lot of causes for this collection of fluids or this ascites, and one of the commonest causes is the liver cirrhosis, and of course renal failure, metastatic disease, peritoneal infections, ovarian neoplasms, trauma, surgery, and sometimes it is spontaneous. And this CT image obtained after contrast injection showed extensive esophageal varices, dilated tortuous collateral venous channels at the region of the gastroesophageal junction. The liver is cirrhotic and there is a good amount of ascites in the peritoneal cavity. Then this is a case of liver cirrhosis, splenomegaly, and the ascites within the peritoneal cavity. You know that ascites can be diagnosed clinically if there is a good amount of fluid in the peritoneal cavity, and now ultrasound is one of the reliable and quick imaging technique for diagnosis of ascites and even for sampling of this acidic fluid to know exactly its nature and to do some of the cytological analysis if needed. Then you know that the fluid usually collects in the most dependent parts within the peritoneal cavity, and if the patient is supine, the most dependent part is the Morrison pouch, which is the space between the liver and the kidney. This is the most dependent area in the peritoneal cavity if the patient is lying in the supine position. While if the patient is erect, then the dependent part will be in the pelvis, in the Douglas pouch between the urinary bladder and the rectum. Then if you look to the fluid within the peritoneal cavity and measure the density of the fluid, you may have some ideas about the nature of the fluid, because water usually measures an attenuation value between 0 and 15 Hounsfield unit, while if this fluid is bloody, for example, you got increase in the attenuation value, and also if it is infected with accumulation of pus, you will see some increase in the attenuation value as well, and enhancement of the peritoneal reflections, as you can see in this particular example. Then many times in the exams it is asked for the candidate to differentiate between ascites and the pleural collection if they are coexisted together. And this is the case of liver cirrhosis and splenomegaly with ascites and pleural effusion separated by the diaphragmatic copula. And you know that ascites is anterior to the diaphragm and the pleural effusion is posterior to the diaphragm. And ascites starts by A and anterior, and the pleural effusion starts by P, and this is posteriorly located. Then hemoperitoneum, the most common cause is abdominal trauma with injury to one of the solid organs, particularly the liver and the spleen. Also, hemoperitoneum may occur after surgery and sometimes may be spontaneous due to an uncontrolled use of oral of anticoagulant drugs. Then you see here there is some laceration in the spleen, and you got hemorrhage in the peritoneal cavity around the spleen and around the liver. And this finding, you can see that the hemorrhage adjacent to the spleen is more dense than hemorrhage adjacent to the liver, and this is known as the sentinel clot sign. And this sign entails that the hemorrhage near to the site of bleeding is more dense than the hemorrhage away from the site of bleeding. Then if you cannot see the laceration in the spleen, you can predict that the spleen is the origin of the hemorrhage, because the hematoma adjacent to the spleen is more dense than the hematoma adjacent to the liver. Then this is, as what I have said, the sentinel clot sign, and you measure the density of the hemorrhage in cases of abdominal trauma, and the hemorrhage which is more dense is more close to the site of the bleeder. Then I'm sorry. The hematocrit effect means that the hemorrhage will sediment in the dependent portions in the peritoneal cavity, forming a sedimentation level. And this is an example of hemoperitoneum, and you see the hyperdense blood which is sedimented posteriorly, forming this sedimentation level, which is known as the hematocrit effect. Then infection of the peritoneum by bacteria, granulomatous disease, and also chemical peritonitis can be occurred due to chemical irritation by contrast media or other material. Then inflammation of the peritoneal cavity will appear in imaging as thickened, enhanced peritoneal reflections, and the collection of multiple abscesses or pus within the peritoneal cavity. The causes of peritonitis include the perforated viscus, the trauma, recent surgery, laparoscopy, and other causes. And here is an example of peritonitis. You see that the peritoneum is thickened and enhanced. There is some fluid or pus within the peritoneal cavity, and these intestinal loops are amalgamated within the peritoneal inflammatory collection, and you can compare the peritonitis by, I'll show to you the normal appearance of the peritoneum. Also in this case, you see a good example of peritonitis. The peritoneal lining is thickened and enhanced. There is pus within the peritoneal cavity. Some is free and some is encysted to form an abscess collection, for example. Then you got the some sort of ileus of the intestinal loops. They are dilated with multiple air fluid levels because they are surrounded by inflammatory material. And whenever there is a collection of pus within the peritoneal cavity, you got a peritoneal abscess, and this is an example of a huge intraperitoneal abscess with air fluid level. And if you look carefully, you can see other abscesses in the retroperitoneal area as well. And this is also a peritoneal abscess, and you see there is thickening and enhancement of the abscess wall, and there is air fluid level inside the abscess cavity. And air can occur within the abscess either due to infection with gas forming organism or the communication between the abscess and the bowel. And this is also an intraperitoneal abscess. You see the thickened, enhanced wall of the abscess cavity and the air loculi inside the lesion. Then one of the causes of peritonitis is granulomatous infection, commonly in our countries like the TB peritonitis, and we have the three types of TB peritonitis. The wet type, which appears in the imaging as just accumulation of fluid within the peritoneal cavity. The fibrotic type will show some omental and mesenteric masses which are difficult to be differentiated from metastatic disease, for example, which is more common. Then the dry type will result in fibrous peritoneal thickening and contractions. And if you look to this case with TB peritonitis, you can see fluid within the peritoneal cavity, and this arrow points to some thickening and let us say soft tissue infiltrations of the peritoneum, and this appearance may draw the attention that this may be a metastatic disease, which is of course seen commonly in the clinical practice compared to the TB peritonitis. But you can predict the appearance of TB, or you can predict the cause of this peritonitis, of this ascites as tuberculous peritonitis, particularly if there are lymph nodes and there are pulmonary TB lesions in the same case. And here you can see just the peritoneal fluid, and there is no clue to say that this is tuberculous peritonitis. And you may have some aspirate and the culture and do culture and sensitivity to confirm the diagnosis. Then if you see peritoneal masses like this soft tissue mass in the region of the greater omentum, and you can see also masses here, and this is ascites, then you think mainly in most of the cases that this may represent metastatic disease, and the diagnosis is usually confirmed if the patient is known to have a primary malignancy. But if the patient is not known to have a primary malignancy, then many times we can go percutaneously having biopsies from these peritoneal masses in order to know the exact nature, which may be the sequelae of peritonitis, especially tuberculous type, or due to disseminated peritoneal malignancy, or due to the primary peritoneal tumors like mesothelioma, for example. Then tuberculous peritonitis is suspected in endemic areas, in the presence of lymph nodes, in the presence of pulmonary tuberculous lesion. Then you see here a stranding and the smudging of the peritoneal fat, and you see minimal fluid in the peritoneal cavity, and as I have said, this may draw your attention to the possibility of primary malignancy, but in cases there is no known primary malignancy and the patient is living in an endemic area known for TB, and the presence of calcium either in the lesion or in the intra-abdominal lymph nodes may lead to the suspicion of tuberculous peritonitis. And this appearance is known as tabes mesenterica or tuberculous lymphadenopathy. And here you see this is the aorta and this is the IVC, and you got multiple marginally enhanced lesions in the anatomic location of lymph nodes, representing retroperitoneal necrotic inflammatory nodes. And this appearance of lymph nodes in our country, for example, is highly suggestive of tuberculous disease, especially if the patient is not known to have a primary malignancy. You know that this is the superior mesenteric artery, and this is the superior mesenteric vein, this is the pancreatic head, and this is the common bile duct, and this is the common pancreatic duct. Then this is a case from our hospital, and you see there are multiple calcified mesenteric lymph nodes as well as calcified retroperitoneal para-aortic lymph nodes. And these are the CT findings that can suggest tuberculous peritonitis. Number one is smooth peritoneum with minimal thickening and pronounced enhancement, mesenteric involvement with macro nodules, mesenteric lymphadenopathy with central necrosis and calcification. Then you remember this case I have presented in the lecture of the splenic imaging, And I have said that whenever you see multiple calcific foci in the spleen or in the liver or both, and you think of post-tuberculous calcification or TB infection of the spleen and the liver. And the same case has also calcific lesions in the lung and the calcified mesenteric and retroperitoneal lymph nodes. This is also tuberculous lymphadenopathy in the chest in a child 7 years old. You see this is the thymus and this is the arch of the aorta. This is the superior vena cava, and you got necrotic lymph nodes in the mediastinum, necrotic lymph nodes in the abdomen, diagnostic of tuberculous lymphadenopathy. Then accumulation of air in the peritoneal cavity is known as pneumoperitoneum, and the best way for detection is the chest X-ray in the erect position. And in the erect position you can see air under the diaphragm, diagnostic of pneumoperitoneum. The most two common causes of pneumoperitoneum are recent surgery and bowel perforation. However, there are many other causes like trauma, like laparoscopy and infection as well. And you know that pneumoperitoneum secondary to operative interference will clear within 3 to 7 days. And if this post-operative air did not clear within 7 days, you should suspect that there is air leak from the bowel or suspected perforated viscous or anastomotic leak. Then sometimes you are not able to have an erect chest X-ray for the diagnosis of pneumoperitoneum, and the alternative is the cross-table lateral view of the abdomen. You know that air will raise up under the abdominal wall, and then you can see this air and you confirm the diagnosis. Then one of the signs that help you to diagnose pneumoperitoneum in the supine position is known as the regular sign. A regular sign means that you can see the wall of the bowel. As here you can see the wall of the stomach, you can see the wall of the jejunum, and this is not feasible unless there is air outside the bowel, meaning that air in the peritoneal cavity. Then the wall will appear in between air in the bowel and air in the peritoneal cavity. This is known as the regular sign. Then we came to some causes of peritoneal inflammations, and we'll discuss these issues: diverticulitis, appendicitis, epiploic appendicitis, pancreatitis, and peritoneal echinococcosis. You know that the diverticular disease of the colon is one of the common lesions seen in the clinical practice, and the diverticuli can were usually diagnosed by barium enema, but now they can be easily also diagnosed by CT and by MRI. And you can see multiple air buckets in the wall of the colon, especially the left side colon, diagnostic of diverticular disease of the colon. But in order to diagnose diverticulitis, you should have three major CT findings. Number one, you see multiple colonic diverticuli containing air. Number two, you see that the wall of the affected segment of the colon is thickened. Number three, you look for the peritoneal fat adjacent to the affected colon. It will be stranded or smudged or reticulated. Then the three issues should be present for the diagnosis of diverticulitis. This is the this is the appearance of diverticular disease uncomplicated of the colon. You see multiple diverticular outpouching here. But in cases of diverticulitis, you see few diverticuli. You see that the colonic wall is thickened. This is seen here as narrowing of the colonic lumen. But of course, in the barium enema, you cannot see the stranded or the stranding of the pericolic fat. But in the CT scan, which is considered one of the modality of choice for diagnosis of diverticulitis, you see multiple colonic diverticuli containing air, and you see that the wall of the colon is thickened and the pericolic fat is stranded. And here also is a case of diverticulitis in the left-sided colon. The colonic wall is thickened. You see few diverticuli containing air, and the fat around the affected segment of the colon is stranded. Then also this is a case of diverticulitis of the sigmoid colon. Colonic diverticuli filled with air, thickened the colonic wall, reticulated pericolic fat. The three items are present. They are essential for the diagnosis of colonic diverticulitis. Then one of the complications of diverticulitis is perforation. And perforation will lead to the formation of a localized pericolic abscess, and sometimes this abscess may involve the urinary bladder, leading to communication between the abscess and the colon and the urinary bladder. Then you got air fluid level in the urinary bladder, secondary to diverticulitis, or to fistulous communication between the colon and the urinary bladder. This lesion is commonly presented also in the exams, where you can see the cause of the air inside the renal bladder. It is the lesion in the colon which has perforated, leading to the formation of an abscess which has communicated with the urinary bladder. Then usually the colonic diverticulitis, whenever it perforates, it will not lead to generalized peritonitis, because the perforation is usually very slow and is usually localized, limited to the pericolic inflammatory changes. Then commonly you see as a complication of diverticulitis a pericolic abscess rather than generalized peritonitis, and this is bilocular abscess cavity with air fluid level inside, thickening and enhancement of the wall. Then epiploic appendicitis is inflammation of the appendices epiploica. The appendices epiploica are fat projections related to the wall of the colon, and these fat projections are not usually seen in the CT scans of the abdomen unless the patient had an intraperitoneal fluid. Then inside this fluid you can see multiple projections that are filled with fat, and these are the appendices epiploica. And here is an example of multiple appendices epiploica containing fat, and this is a big one, appendices epiploica. It is seen clearly by virtue of the surrounding fluid in the peritoneal cavity. Then these appendices epiploica, being freely mobile, they can be tortured and resulting in compromise of the blood supply, getting into ischemia and inflammation. Then the issue with these findings will appear in the CT scan, like this lesion, which is composed of three parts. There is a margin outside, the margin surrounding the lesion, which represents the parietal peritoneum, and this is the fat of the appendices itself, and this is the vessel which has been thrombosed secondary to torsion. Then around this lesion in the outside area you can see reticulation and stranding of the fat plates. Then this is known as epiploic appendicitis, and this is a lesion which cannot be diagnosed unless you are looking for it, and frequently it can be missed through the images. If you do not look carefully and think of this lesion being a cause of acute abdomen, you cannot find this lesion easily. Here is you see the thickened parietal peritoneum, the reticulated fat, and the fat of the appendages itself. And sometimes you cannot see the vessel, and sometimes you can also see the vessel. Then if you look carefully here, searching for this appendages epiploica, it is difficult to be located actually, unless you think of this lesion as a cause of acute appendix. Then appendicitis is inflammation of the appendix, and you know that the appendix is a tube which is normally filled by air, and sometimes you can see it in the CT scans, and we used in the early days of barium studies to give the patient barium, and either usually we give the patient oral barium and image the area of the ileocecal region 3 to 4 hours after barium intake, looking for the appendix to be filled with barium like this. But many times the appendix fails to fill with barium, and this was not a sign of appendicitis, for example. But you know that the major cause of appendicitis is obstruction by foreign body, by food residue, by tumor, and this obstruction will lead to increased intraluminal pressure inside the appendix, which will result in venous engorgement and arterial compromise, consequently with tissue ischemia. Then you got infarction and microperforation. Ultrasound is one of the good tools for diagnosis of acute appendicitis. And here you can see that the appendix is dilated, it is filled with fluid, the wall is edematous, and many times you can see this foreign body inside the appendix, which is known as appendicolith or fecolith. And this is considered the main cause for obstruction of the appendix resulting in acute appendicitis, and frequently it shows this characteristic posterior acoustic shadowing. As I have mentioned, there are other causes of obstruction of the appendix like parasites, primary and metastatic tumors. Then in the CT scan, you can see that this is the appendix, which is dilated, the wall is thickened, it is filled with fluid, and this calcified lesion represents the appendicolith, which is located at the neck of the appendix. And if you look carefully around the appendix, you can see a stranding of the fat planes. This is acute appendicitis by ultrasound, and this is the appendicolith, which is clearly seen inside the dilated fluid-filled appendix. And sometimes you cannot see this appendicolith, but you see that the appendix is here, it's dilated, the wall is thickened, and it is filled with fluid with reticulation of the periappendiceal fat. Actually, you need the help of the clinical data in order to suspect that this may represent the appendicitis. Sometimes there is perforation of the appendix leading to the formation of an abscess in the appendicular area or in the right iliac fossa. And in this abscess, you can see the appendicolith, which was the cause of obstruction of the appendix and later on perforation. Then you are sure that this abscess is of appendicular origin. As I have mentioned in the lecture of pancreatic imaging, that after pancreatitis you got fluid collection in the region of the pancreas, which is known as the pseudopancreatic cyst. And this pseudopancreatic cyst may be secondary infected, resulting in pancreatic abscess. And I have said that in order to differentiate between the pseudocyst and the abscess, there should be some air inside the collection to predict the nature of being an abscess. And also I have said that this air is not frequently seen inside the lesion, and if you cannot see air, you are not able to distinguish between abscess and pseudocyst in spite of the clinical data. And frequently we put a percutaneous needle or catheter in the collection and got some fluid for analysis. Then you know that a hydatid disease can affect the liver. I have explained this in details in the lecture of hepatic imaging, and also can affect the pancreas, the spleen, and also I give some hints about this in the splenic imaging lecture. And sometimes this hydatid disease can occur in the peritoneum. And the peritoneal echinococcoses are usually secondary to rupture of a hepatic hydatid cyst into the peritoneal cavity. And this may be a spontaneous rupture or during surgery attempting to remove this hydatid cyst. Then you got the spread of the hydatid disease into the peritoneal cavity, resulting in multiple cystic fluid-filled structures having the same criteria of hydatid disease, which include mural calcium in some cases, floating shadows in some cases, and cysts, daughter cysts within a larger cyst in some other cases. Then this is a case of peritoneal echinococcoses, and you got too many cystic lesions with some internal daughter cysts and a small cyst in between representing multiple hydatid disease. And this is also peritoneal hydatidosis, and you got too many hydatid diseases in the peritoneal cavity. And of course this is a surgical indication for removal of these hydatid diseases, the hydatid cysts from the peritoneal cavity. And this is also a case of peritoneal echinococcoses, and you can see the surgical removal of too many hydatid cysts from the peritoneal cavity, and these are the lesions scattered within the peritoneal cavity. هذا وبالله التوفيق والحمد لله رب العالمين.